Good afternoon. Welcome to this session of GSI. and the theme of this session is minimizing morbidity caused by glaucoma management, tips and tricks. So, certain important aspect in this will be discussed, and it will be really there will be some take-home message for all of you. So,
May I request the people sitting at the back to come forwards for better understanding, because this is a very very serious type of matter, and there'll be take home message for everyone.
This is there. No? This is there. This is Dr. Dilip Lal.
so, so first we invite Dr. G. Chandrasekhar, and if I will be introducing him, it will be insult to him because I cannot introduce him. He's so well-known figure in the country and abroad. So the topic that he is going to talk is diagnosing glaucoma suspect, tips and tricks to minimize physical and psychological morbidity. GC आया तो
Is that better? Can you hear me? Okay. Slide is not advancing. Okay. Okay. So we make the diagnosis of glaucoma based on intraocular pressure, do a gonioscopy to differentiate open angle and angle closure, and looking at the optic nerve carefully and doing the visual fields and corroborating the damage that the intraocular pressure or other factors have produced is what will establish the diagnosis. I think it is important to collect information on each of these parameters in a totally unbiased fashion and then interpret the findings in correlation with each other. More importantly, we need to appreciate the limitations and pitfalls while we gather information about each of these findings. While we are thinking about the diagnosis of glaucoma, we are worried because we don't want to be potentially missing a blinding disease, and the misdiagnosis is going to be very costly on our responsibility as a doctor. But the patient's concerns once we make even a diagnosis of glaucoma suspect would be fear of impending blindness, especially if somebody in the family has gone blind. Once you make a diagnosis of glaucoma suspect, the patient remains a suspect throughout his life. Nobody is going to delabel him. The psychological trauma of the diagnosis, and if the therapy is initiated, the trauma of the over-therapy. So talking about intraocular pressure, the only message I want to give is that non-contact tonometer cannot be used to make either diagnosis or follow-up glaucoma patients. Because the pressure is measured in such a short span of time, 1 by 500 of the cardiac cycle, the variability is enormous. And if you do end up, an example of what can happen. So the patient was started, 38-year-old lady on timolol, the pressures were not controlled, dorzolamide was added, and then bimetoprost was added. The pressures are still not controlled, the patient was advised surgery. Then she came to us. The discs were completely normal, the angles were open, the fields were completely normal, and over a period of time we took out all the therapy, and with an appellation tonometer, pressure remains normal. So non-contact tonometer is a screening tool if at all, and sitting in the glaucoma in the practice, we are not screening patients, we are doing a comprehensive examination. So a non-contact tonometer actually does not belong in the clinic, is my message. Should not be used to diagnose or manage follow-up. As far as gonioscopy is concerned, this is the only instrument that can differentiate between primary angle closure suspect and primary angle closure that will decide whether you need to do an iridotomy or not. While doing gonioscopy, we need to answer two questions. As a starting at the time when I was starting my gonioscopy, the target is whether I've seen the trabecular meshwork or not. If that is the target, then all angle closure glaucomas will be missed. So the first important thing is the angle occludable? And for that, we need to make sure that the room is dark, the slit lamp illumination does not fall on the pupil, and there is no indentation or manipulation, allowing the pupil to dilate to its maximum, and then assess the gap between the cornea and the iris. Having made that judgment, then you can go on to see what else is there in the angle and what pathology you are looking at. So an example of an occludable angle, on indentation opens up with a blotchy pigment there that is indicative of angle closure. So if you are doing only this and don't pay attention to the blotchy pigment, you will probably end up treating this as an open angle glaucoma while the patient has primary angle closure. What looks like a pigmentation on the back of the cornea, on indentation, turns out what looks like a trabecular meshwork is actually pigmentation on the back of the cornea, indicating angle closure, made up by indentation. What looks like a synechia, once you do indentation, disappears. These are peripheral bulges on the iris that look like synechia, but they are not true synechia. A closed angle, opening an indentation with a hemispherical bulge on indentation that turns out to be a ciliary body cyst. So if you increase our skill on gonioscopy, it's like a UBM in your pocket. You can make out much more changes. While the imaging technologies are beautiful to look at, because their magnification is so high, they are looking only at a very, very small part of the angle. For you to make a clinical diagnosis, you need to be looking at 360 degrees of the angle. While the newer technologies of imaging probably can do that, they cannot do indentation. So your management of angle closure glaucoma cannot be done if you don't do gonioscopy. And it's important to remember that in our current context, angle closure disease can masquerade as glaucoma suspect because we see the disc only after dilation. We haven't done the gonioscopy. Ocular hypertension is a diagnosis that can be made only if you have made a good gonioscopy. Normal tension glaucoma, I have seen patients being treated as normal tension glaucoma where actually the disease is angle closure. Intermittent pressure rise, disc damage is produced, angles chamber is deep but angles are occludable. Even if you diagnose primary open angle glaucoma, over a period of time they can go on to develop angle closure disease. So we need to be repeating gonioscopy every year. So looking at the optic disc, I think the most important lesson to learn is that this small disc that looks perfectly healthy is glaucoma, and all the other three are physiological variations of the optic disc because of the variable disc size. Looking at the disc, trying to draw the diagram is the only way we will probably pay attention to detail. A large disc, even if it is glaucomatous, can make you overestimate the amount of damage. Between these two discs, both are glaucoma. The damage in the right side image is much more than the damage in the larger disc. So you tend to overestimate. Ultimate goal should be we not only make a diagnosis of glaucoma, but by looking at the nerve fiber layer changes and the notch, actually see how much of damage is likely to be there. All superior field damage, but the severity of damage can be made out by looking at the nerve fiber layer loss. This looks like this is an unreliable visual field, but there are some depressed points in the inferior points. The optic disc evaluation shows that there is a superior nerve fiber layer defect. So even this unreliable visual field, because it correlates with your clinical examination, very early loss, not satisfying all three Anderson's criteria, can be a diagnosis of glaucoma. If you're not confident about picking up this early change on the optic nerve head, then you go on to do imaging. And the imaging shows that in the left eye, there is a superior nerve fiber layer loss, superior GCPIL loss that correlates with what you're suspecting clinically. So that is what makes the diagnosis. If you see a disc like this, where there is damage both superior pole and inferior pole here, only superior pole here, and the red of the imaging and the black of the visual field are matching with each other. So that's what makes the diagnosis. On the other hand, there is red everywhere, the disc is healthy, the black is not there of the visual field. So that's a false positive. That's what you need to remember. So this disc looked normal to me, but the patient had a repeatable visual field defect in the superior hemisphere. Then I depend on imaging. Don't go by the averages, but look at this superpixel loss inferiorly. So that is how we need to use imaging. Because early glaucoma is where you need imaging, and the damage takes place only in one hemisphere, either your disc or your field that you suspect should correlate with the damage that you see on the imaging. But just by looking at imaging, you cannot diagnose somebody as having preperimetric glaucoma. So we talked about the patient's concerns and the doctor's concerns. One last point, maybe take a little more second. We worry about the blindness in glaucoma without realizing the natural history of the disease. What this study showed is that the progression to glaucoma is very small if you look at the natural course of the disease. All diagnosed as glaucoma, extrapolated progression, there are significant number that actually improve, significant number that progress but do not go visually handicapped, and a very small number go to handicap and blindness. That is what we need to differentiate when we deal with a patient. Overdiagnosis in the early disease, missing the established disease, and under treatment in severe disease are the ones that we need to be careful about. Thank you for your attention.
Thank you, sir. Thank you, Dr. GC, for this wonderful talk. And I think something which he has been teaching all of us is that the moment you tell you are a glaucoma, the moment you tell this to a patient that you are a glaucoma suspect, the quality of life goes down. And there's so much of psychological impact that it has of suffering from a blinding disease. So, with these few words, I invite the next speaker, that is Dr. Tutul Chakravarti. She will speak on medical management of glaucoma, tips and tricks to minimize the morbidity caused by drugs. So the theme is to reduce the morbidity caused by the treatment.
Good afternoon. Today's topic, medical management of glaucoma, tips and tricks to minimize morbidity caused by drug. Now, this is the chronology of the introduction of topical IOP lowering medications, and systemic carbonic anhydrase inhibitor have been available since 1955. Apart from these conventional eye drops, 3 new topical IOP lowering agents are Vyzulta in 2017, Ropresa netrasodil, and Roclantan, that is in 2019, a fixed dose combination of netrasodil rokinase inhibitor and latanoprost. Now, regarding percentage of IOP reduction, the maximum is with netrasodil latanoprost fixed dose combination, that is 30 to 36%, and Vyzulta 30 to 34%, prostaglandin analog 25 to 35%. However, the netrasodil is 16 to 21%. The prevalence of ocular surface disease is 59% in glaucoma cases, with higher prevalence in patients using anti-glaucoma medication containing BAC. Now, preservative is a major source of toxicity for the ocular surface. Ocular surface disease related to anti-glaucoma drugs, we can try to explain with this flow chart. It could be a results from the allergic mechanism or results from toxic mechanism. When it's an allergic mechanism, relatively rare and seen in the early phase of the therapy, it could cause of chronic ocular surface disease. Now, it could be related to preservative or it could be related to active component, and BAC commonly used preservative. Next is if it is related to active component, the symptoms and signs associated with the number of concomitant drugs and the number of eye drops instilled per day. Now, BAC is cytotoxic, all we know, at the concentration of more than 0.005%. Now, this tafluprost and tavatan, that is not without BAC. However, there is another view. Now, there is no evidence from double mass RCTs that BAC causes significant ocular surface disease over and above glaucoma medication alone in patients with a healthy ocular surface. Preservative-free preparations are desirable in patients taking more than 3 medications or in those with pre-existing ocular surface disease. Based on current evidence, there is no justification for routine use of preservative-free medication in those without significant ocular surface disease, and especially those requiring only few medications like 1 to 2 per day. Next comes to adverse effect related to active component. Now, allergic conjunctivitis is related to beta blocker bimonidine and dorzolamide. Conjunctival hyperemia is common with beta blocker bimonidine and prostaglandin analog, and the most common is bimatoprost. Lacrimal dysfunction, meibomian deficiency, reduction of goblet cell density, and dry eye is related to beta blocker and prostaglandin analog. Now, skin pigmentation and dews is also related to prostaglandin analog. Transient hyperemia can be seen with ripasudil instillation. The occurrence of the deepening of the upper eyelid sulcus with prostaglandin analog was first reported with bimatoprost in 2004. These are the other side effects of conventional eye drop. Now, how to decrease the adverse reaction to glaucoma eye drop? Now, first educating the patient on possible adverse reaction. These effects may be minimized with a low concentration, reduced frequency of administration using nasolacrimal duct occlusion and gentle eyelid closure for 2 to 3 minutes. Now, adverse side effects is expected if too many eye drops are administered in too short a time. If eye drops spill during administration, the risk of blepharitis and eyelid pigmentation increase. Carbonic anhydrase inhibitor side effects are common but not well understood. Switching drugs like from acetazolamide to methazolamide when patients are not are intolerant of a particular carbonic anhydrase inhibitor. However, there is another way we can reduce the dose of carbonic anhydrase inhibitor or gradual dose increase. Now, administering sodium bicarbonate or potassium or taking the carbonic anhydrase inhibitor drug with meals are unproven remedies. Switching from one drop to other drop can improve the symptom. In beta blocker, switching from one beta blocker to the other often improve adverse reaction. In PGA, the incidence of conjunctival hyperemia with latanoprost is low. Consider prescribing latanoprost first or switching patients with conjunctival hyperemia to latanoprost. Consider prescribing latanoprost or tafluprost in patients with DUS with bimatoprost. Please remember that some patients do not respond to the treatment with prostaglandin analog. IOP lowering efficacy differs significantly between individuals, partly owing to the genetic factors. Now, preventing preservative-induced reactions, low concentration eye drop and least frequent dosing schedule should be considered initially to reduce the risk of adverse reaction. Trying medication in one eye first to evaluate the IOP lowering effect of a glaucoma medication on a specific patient. Switching the patient to eye drop with preservative other than BAC or preservative-free eye drop. Fixed dose eye drop can be prescribed in patients who are on multiple therapy. Now, long-term prostaglandin analog use may change the shape of the cornea and corneal biomechanical factors, including CCT. So, in long-term use of prostaglandin analog, regular monitoring of corneal topography and CCT measuring are necessary. Consider the possibility of such changes when selecting prostaglandin analog for patients with pathologic corneal thinning or after refractive surgery. PGA should be avoided in the early postoperative period in keratoprosthesis patient management. Application of dorzolamide for one day results in a slight but statistically significant thickening of central corneal thickness in patients with corneal gutta. Decreased corneal sensation has been reported in patients treated with topical beta blockers. Because of the local anesthetic effect, repeated check of corneal sensitivity is recommended during beta blocker therapy. Now, topical anti-glaucoma medications and the success of glaucoma filtration surgery. Withdrawing medication 4 weeks prior to trabeculectomy surgery and use of preoperative anti-inflammatory medication can improve failure rates of trabeculectomy surgery. Fluoromethalone reduces conjunctival inflammation prior to trabeculectomy. There is no conclusive evidence that BAC jeopardizes the success rate of glaucoma filtration surgery. 0.1% sodium hyaluronate or 0.5 carboxymethyl cellulose are indicated for mild dry eyes. Patient with moderate to the severe dry eye should use artificial tear with higher viscosity such as 0.3% sodium hyaluronate and 1% carboxymethyl cellulose. Now we could conclude that individualist assessment is the first step in provider-patient communication. Medications with good IOP lowering effect and requiring less frequent use should be selected like prostaglandin analog. Initiation with combination therapy may be appropriate in selected patient. Now be aware of potential impact of the IOP, topical IOP lowering medication on blood pressure, especially the nocturnal diastolic blood pressure, diastolic ocular perfusion pressure, especially in case of normal tension glaucoma. Please remember that the minimal IOP lowering efficacy of beta blocker during sleep and evaluation of the ocular surface should be included as a routine part of the follow-up of patients with glaucoma. Thank you.
Present. Thanks for nice presentation, and you have nicely elaborated the points for minimizing the preservative side effects. Now I will invite next presenter. Minimizing intra and postoperative morbidity caused by tube shunt by tips and trick, Dr. George.
During the time Dr. George starts his talk, so regarding, because the previous talk was very, very important regarding the medical management. So what we need to do is we need to first step to minimize the morbidity caused by treatment is to give minimum drugs. And to be able to give minimum drugs, the first step is to start the drugs one by one, not to start multiple drugs at a time. Give a unilateral trial and keep the patient informed about the side effects. This is very important so that the patient presents first as soon as there is a side effect noticed. And nasolacrimal drug and use of fixed drug combination to minimize the preservative free drugs. So these are the few tricks which can minimize the morbidity of treatment. Dr. George, please.
Thank you, sir. Thank you for the opportunity. So selecting the quadrant for implantation of the episcleral plate of the glaucoma drainage device is vital. And the most preferred location is the supratemporal quadrant, ensuring that there is adequate conjunctiva and tenons for good closure. On certain occasions, due to some anatomical impediments, like you have a staphyloma in the supratemporal quadrant, or you need to plan a repeat tube, usually the next quadrant of preference is the superior nasal quadrant. Sometimes the whole of the superior quadrant is compromised by in this patient by a trauma with ciliary staphyloma. So you need to go inferiorly to place your tube to manage the refractory glaucoma, and usually we prefer to have it in the inferior nasal quadrant. Also, if you need to plan a repeat tube where the superior nasal quadrant is compromised, again the quadrant of choice is inferior nasal. Another important tip is that your end plate of any glaucoma drainage device has to be 9 to 10 millimeter posterior to the limbus. All those anteriorly placed episcleral plates have huge potential to create complications. And always try to stick to a single quadrant. See, everything has gone wrong here. It's not in the quadrant, it's placed superiorly. The wings of the non-valved implant has to be positioned beneath the muscles. The wings are outside, the anterior edge is migrated forward. There is a longer than adequate length tube in the anterior chamber. Again, use of 3-0 supralon suture for intraoperative stenting of non-valve devices have made the surgery much more safer. You use the intraoperative supramid stenting, and you have those 6-0 vicryl ligature sutures, one above the stent supramid and one beyond that. So temporary occlusion of the tube is vital in non-valved implants. Usually the fibrous capsule has to form well above the around the episcleral plate. This usually takes about 5 to 6 weeks, and by that time the ligature suture dissolves and the tube patency is established. Again, with the advent of this supralon suture, which is now freely available, chronic hypotony was an issue with non-valved implants, and an ab interno supramid stenting has definitely made life much more easier. There is something really predictable to take care of this chronic ocular hypotony seen in a very late stages of, especially with a non-valved implant. You could use it even if you have a hypotony with a valved implant. Also, you could use this procedure. So this is a 2.2 bevel up keratome entry into the anterior chamber. We usually prefer to have these keratome entries rather than your sharp paracentesis. These seal off much better. So this is the multi-filament supralon suture. The competitor brand is the Supramid suture. So this is the multi-filament. This is 3-0 nylon, and usually we measure approximately the corneal diameter to do this ab interno stenting. So it's around 11.5 millimeters, and a sharp bevel is made on one particular end, and this can be easily guided into the lumen of the tube through a paracentesis about 180-degree away from the position of the tube. So now here we are not touching the conjunctiva. Earlier we may have to open up the tube, open up the area of the conjunctiva near the tube, ligate it 6-0 vicryl. And this has also been published, and it's a definite way to take care of your chronic ocular hypotony seen many years after implantation of the glaucoma drainage devices. That is a microrhexis forceps which is being used to guide the supramid into the lumen of the tube. Again, tube position in the anterior chamber is critical. You just cannot see on a cursory glance, this looks like everything looks fine. But here, see, if you make a slit, the slit on the tube is very close to the slit on the cornea, and the slit and the distance between the iris and the tube is much more than what is actually ideal. It should be as close, and no wonder over a period of time the cornea started decompensating. It just cannot be left close to the endothelium. Uh, you have to find ways to make sure that the tubes are positioned as close to the iris intraoperatively, and it should be. And if you make a slit right from the entry into the anterior chamber, this distance should be maintained. Distance from the cornea, the slit on the cornea, the slit on the tube, and slit on the iris. If you see very carefully, see this distance and compare the distance from the tube to the iris. Find ways to make it work in your hands. Uh, this is a 3 millimeter distance. We usually find that if you dip into the anterior chamber, you go into the scleral tract, and if you dip between this 2.8 and 3 millimeter, usually you get a good position of tube in the anterior chamber. Also, some precise measurements, like you drape the tube over the cornea, measure 2 millimeter, make an anterior bevel, and if you position this tube 2 millimeter medial to the initial position of the tube, you get an adequate 2 millimeter length of the tube in the anterior chamber. Initially, we were always worried about these long tubes, short tubes. And we also found that having a sinuous route like this, secondary interventions, if we had to see, this was the tube which was very close to the cornea, we had sufficient length of the tube still available because of the sinuous route to reposition it back into the anterior chamber at a different position. Here was a tube retraction, again repositioned without the use of a tube extender or other tube extending devices. A note that shallow ACs are common even with valved implants. Mild choroidal effusions can cause shallow ACs. Usually, with conservative treatment, most of them form well. But here was a patient. This was the third day post-op, fifth day post-op, still shallow AC. Provided the B scan doesn't reveal any hemorrhagic choroidals and the pressures are still low. Uh, Keep this in mind that you might a valve malfunction is possible with an AGV, and you might have to go and ligate the tube to to get the chamber formed. Tube exposures rarely occur 4 millimeter beyond the limbus, and burying the tube in the patient's sclera for this 4 millimeter is sufficient insurance against tube exposure, which is usually a big headache for the glaucoma surgeon. One last point about the hypertensive phase usually occurs after the tube ligature dissolves in non-valved implants. It's much later than in the AGV, where it usually occurs in between 4 to 6 weeks. Tenon cyst encapsulated blebs are much more common with the valved implant. Um, it's extremely important to start aqueous suppression right at the immediate post-op. If the pressures are 10 millimeters or above, we just start a fixed drop combination from second post-op day in AGV, and also continue the drug combination in a non-valved implant after 6 weeks after the ligature suture is opened up. The inflammatory mediators reach the subtenon space much less with aqueous suppression, and chances of these bad encapsulations are less. I just want to conclude saying we still do not have the perfect GDD, but a lot of work has gone into the intraoperative surgical technique to ensure that many of these patients' useful vision is preserved at sometimes even with a multiple GDD. Thank you very much.
Thank you, Dr. George, for giving us the tips. And after I think that we are going to have the last talk. Then, if there is some questions from the audience, we will try to get the answer from the speakers and the panelists. So the next one is going to talk about MIGS, tips and tricks to minimize intra and post-operative morbidity. Dr. Sunita Dubey.
Okay, thank you. Good afternoon, everyone. Slides are not moving. Yeah. So MIGs are used either as surgical device that incises, excises, or ablates the TM, like in GAD, KDB, and trabectome, or as an implant, like in iStent and Hydrus. So generally, MIGs are performed after the options of medications and lasers are being exploited, with or without cataract surgery. However, they can be done even after cutting surgeries. So compared to traditional glaucoma surgeries, MIGS have fewer risks and complications, faster recovery time, they can reduce the medical burden and therefore improve the quality of life. However, they definitely have a steep learning curve. So one should be very well aware of the prerequisites of angle procedure before starting the procedure. And most importantly, one should master the art of gonioscopy, which is a key to successful procedure. And we are used to coaxial illumination while operating cataract surgery or other intraoperative surgery, but in MIGS, one has to get used to the microscope setting and positioning, wherein you have to tilt the microscope 30 degrees towards you and patient's head away from you, so as to have an angle of about 70 degrees. So this is very, very important, and you need to choose the open angles, especially during your learning curve, so as to have the en face view of the angle, wherein you see all the angle structures very clearly. And also it is important to review the comorbidities the patient may be having, and patient should be able to follow these commands intraoperatively, like tilting the head or moving the eyes away from the specific direction of gaze. So it's very important to counsel the patient preoperatively. So you can even use this calculator tool, which is available online, which takes into account a lot of prerequisites or the preoperative requirements which you should monitor, and you should document in your file before performing the MIGS procedure. So you can use any of these lenses, gonio, which are the gonio Vogue surgical lenses, eye prism, or disposable lenses. However, take care that you do not compress the cornea. The gonio lens should keep floating over the bed of cohesive viscoelastic over the cornea. And this will avoid corneal folds and improve the visibility, and use high magnification to observe all the structures clearly. As I said, and fast view of the angle. Now, as far as the incision is concerned, when you are combining, even without cataract surgery, you have to give incision, a clear corneal incision, so as to avoid the limbal bleeding. Because if you make the incision at the limbus, you can nick the limbal vessels, which can hamper the visibility of your procedure, because it can just spread over the cornea. A 1.8 millimeter incision is enough uh, to have good maneuverability from side to side, and incision can be flared posteriorly, so you can just enlarge the incision from inside to allow greater excisional range, wherein you can just keep rotating your gonioscope and treat the angle. A Aioc dual blade goniotomy is specifically designed to treat the angle, as it has a sharp tip which pierces the TM. The ramp lifts and stretches the TM and feeds it into the dual blade, and the heel of the foot plate nicely settles within the canal. So with this device, there is no collateral damage and it is very safe. So aim for a very precise technique under good visualization, under high magnification. So as you engage the trabecular meshwork, you have to move along one side of the canal, as you can see, and you can nicely see this strip coming off. So be very careful that you are excising the right area. And once you have completed on one side, but just keep moving your gonioscope over the cornea. You just rotate your tip and do it, the procedure, complete the procedure on the other side. So you should see this trabecular strip, which should come out during the procedure of KDB blade or bang. And after that, you can finish off your cataract surgery, and then just remove the strips. So you can remove the strip as in this video. after completion of procedure with this the help of this micro forceps. So you can just take out the strip nicely. Also, it is important to elicit this episcleral fluid wave. So when you hydrate, you can see blanching of the vessels. So initially when you see there are vessels which are seen filled with blood, but when you inject fluid through your hydroincision, you see this episcleral blanching of vessels, and the success depends on the patency of distal collector channel. So when you combine these procedures with cataract, I usually perform cataract first because uh, the big advantage is that the eye is not hypotenuse and it will not lead to excessive blood in the Schlemm's canal, which can hamper or obscure the view. So I perform the cataract surgery first, as in this particular patient, a patient with trauma, with traumatic cataract, intractable glaucoma. He had this total traumatic cataract with PC rupture. So you can see before doing the cataract surgery, you can visualize the angle properly, make a cleft. The angle was open in this particular patient. And once you have made a nice cleft, then you can continue with your cataract surgery. Although it is not hard and fast, you can even perform cataract surgery first and do the goniectomy later. So this patient had PC rent because he was a traumatic cataract. So the vitrectomy was done, and then 3-piece IOL was implanted in the sulcus. So the patient did well after the procedure, and the nice cleft was seen. As far as GAT is concerned, again, there are certain points which you need to keep in mind, that when you're doing this 2 millimeter goniotomy should be done. The goniotomy should not be very big, otherwise it will be difficult to insert the proline suture. So once you have done the goniotomy, you should use this mushroom-tipped proline suture and advance it in a counterclockwise direction along the circumference of Schlemm's canal, and you should not feel any resistance. Because if you're feeling resistance, then you may be not in the Schlemm's canal. You just pull it on the other side so as to incise the trabecular meshwork 360 degrees. So it's very, very important that you don't feel any resistance. If you are feeling any resistance, you can use your indirect gonioscope to visualize whether the proline suture is in the angle. Last, the eye stent. Again, it is available with the injector. So here again, as I said, you need to have a very good view and fast view of the angle, because you have to actually implant the device into the trabecular meshwork. So you just indent the trabecular meshwork, the anterior part, keep the trocar perpendicular to the TM and gently dimple it. It should not be too much or too little, and this reflux of blood is a good sign that you're close to the aqueous vein, and then just move 2 to 3 millimeter away and implant another device. So it comes with 2 eye stent injects. And then just check the position of the implants intraoperatively only, that they are nicely placed in the trabecular meshwork. So post-operatively, again, depending on the inflammation, you can give the patient steroids 6 to 8 times and then gradually taper them off. Monitor for the elevation of IOP. Sometimes, especially in GAT, you can get hyphema, which will clear on its own within days or weeks. It rarely requires an AC wash. Prolonged inflammation, I think you should have a check, because it can lead to PAS and it can close the cleft. Gonioscopy should be performed frequently to check for cleft patency and formation of PAS. So to summarize, intraoperative gonioscopy is truly a foundation for MIGS, and success starts at clinic with proper patient selection. As I said, you just have that patient selector tool, and you should document each and everything preoperatively so that you don't have any problem intraoperatively. And I would advise that you should practice these procedures in the wet lab to get used to the bimanual conditions. And good visualization and understanding of the angle is the key. To start with, I would advise that you can start with more simpler procedures like bang and then switch over to the other procedures. Thank you very much.
Thank you, Dr. Sunita. Thank you so much for giving us insight into the mixed surgery. Last वाली slide, please keep it on. Last वाली, इससे पहले वाली slide. Previous slide, please show us the previous slide. Yes.
Yeah.
So, no, not this one. After this.
Which
No,
one?
there was. Okay, so I think this one, correct. So the first and foremost thing in this, those who want to start mix, is to learn intraoperative direct gonioscopy and tilting and positioning of the microscope. So this is the first thing, and there's a foundation of this. And of course, wet lab practice has to be done. And so thank you so much for this. And I think now we'll have the most discussion. The first and foremost discussion will be on the most important topic, and that is reducing the morbidity of during trabeculectomy. And that will take up in the panel discussion. I request Dr. Sunita, Dr. George, Dr. Tutul, Dr. Reena, and
Parag
uh,
Sharma.
Dr.
Parag
Faraj
Sharma.
to come on the dais. And so this is, and in the meantime, our panelists they settle down. I request all of you to join us for annual conference of Glaucoma Society of India to be held in Pune from 6th to 8th October 2023 in Hotel Hyatt Regency. And I am Dr. Manavdeep Singh, the secretary, and Dr. Varun Naik is the president of Glaucoma Society of India. You can contact us or you can see the website. All the members of All India Ophthalmological Society are getting the emails also inviting them to this conference. So 6 to 8 October, annual conference of Glaucoma Society of India. Uh, sir, can we start asking the questions from the
Next
panelists?
question to Dr. Sunita. What is the mean IOP drop in from the baseline in your KDB patients or GAT patients?
So the mean IOP, I think it's not working.
Okay, okay.
The mean IOP drop in KDB patients is around 20 to 25%. So it is not as good as trabeculectomy, but it is equivalent to one or two medications. So it is 20. And in GAT, I think it is slightly more, maybe 32%. Although I have not realized the results of GAT, but KDB, I have pretty good experience of doing 60, 70 cases. So in more or less all the patients, the drop was 20-25%.
What type of patient you want to take, moderate to severe or early to moderate?
See, I have taken mostly mild to moderate glaucomas in my series, but as I had shown some of the patients, I think I found it very useful in patients of secondary glaucomas, which have very high pressures like traumatic glaucomas or steroid-induced glaucomas, where the glaucoma is not long-standing. So the basic principle of doing mix is that you should have the patent distal collector channels. So if the glaucoma is not very long standing, then your distal collector channels, the possibility of having patent distal collector channels is pretty high. So that is why I found it very, very effective in patients with short-term glaucoma and intractable glaucoma. So the IOP reduction is pretty good.
So right now, I think we will not continue discussion on mix because still whether in India it is how popular it's going to be, that time will tell. But right now, it's not popular at all, and there are so many reasons for this. One is the steep learning curve, very high cost, and one suggestion I would say that whatever you are telling, the abbreviations the ophthalmologists are sitting here telling bang, you're telling cape, KDP. So those things, no, means they don't know what is that. So those things should be clarified. But anyway, now we move on to the thing which was not covered here, trabeculectomy. So I will ask each speaker just to say 3 points which you should take care while doing trabeculectomy so that you minimize the morbidity and the side effects. So from Tutul.
Sir, regarding if the patient is on long time, anti-glaucoma medications, I would like to say that before surgery, that at least 4 weeks, that especially the beta blockers and prostaglandin should be stopped, and patient can be on Diamox on that period, and patients with low dose fluoromethalon or any steroid eye drop low dose, just to reduce the inflammation of the caused by the anti-glaucoma medications and preservatives.
I think she mentioned the pre-operative important messages. I'd like to add that on the table, few things that help minimize the post-operative risks are on the table. One is when you're using mitomycin C, make sure the conjunctival edge is not touched with the mitomycin C soaked sponges to avoid the chances of post-operative leakage. And also when you're making the flap, now we are all doing fornix-based conjunctival flaps, and preferably a rectangular flap, but with many surgeons the triangular flap works well. But the important take home message is that we want posterior filtration, so we usually don't like these flaps to go all the way till clear corneas. We stop short on the sides, but we just enlarge the central area to make sure that you reach the clear cornea where you make the entry, but the edges are stopped short of the limbus so that the filtration will happen more posteriorly. And meticulous closure of the conjunctiva at the end of the surgery is extremely important. And also checking the filtration on the table so that you know what you're going to achieve in the post-operative period. There are many more points, but I'll ask the other person to mention that.
So my point, intraoperatively, pre-op has already been covered. Steroid, I think, is a must, especially if the patient has been using anti-glaucoma medications for long to improve success. The other thing I would give or I would apply to all my patients a releasable suture, because that gives you the option of having the normal or slightly high pressure intraoperatively and an option of having low or increasing flow post-operatively. So I think that will prevent your complications of hypotony in the immediate post-operative period. So I think that is very important. And post-operatively, I think digital massage and release of releasable sutures, I think these are some of the things which are very important to improve the success.
But the patient will be concerned that you are stopping anti-glaucoma medication 1 month before. So in between, what will you give? Will you give anything?
Diamox can be used in that case.
No, can be, or you are using it?
No, we are not stopping the anti-glaucoma drops.
No, because she suggested
don't
no, the
stop.
stopping.
No, we do not stop.
No, stop the anti-glaucoma medication topical, but a
No,
patient can
But
we do
very
not
often
stop.
it's very hard to do if these patients are on
patient
budget.
can take Diamox at least half of 3 times a day, or if a patient can tolerate.
Usually, some eye specialists are stopping PG analog, but usually we don't stop anti-glaucoma. We don't stop it. Dr. George, you are coming.
Yeah, I think especially for the younger age group, travoprost and bimetoprost are supposed to cause a lot of conjunctival inflammation and fibrosis. So we prefer to, if you want to have a prostaglandin, it is always preferable to have the patient on latanoprost rather than bimetoprost or travoprost preoperatively, especially the bimetoprost. But we don't completely stop anti-glaucoma medications for logistics reasons. Ideally, it would be good to stop anti-glaucoma medications and give a low-dose steroids for a period of 3 to 4 weeks pre-operatively to enhance the filtration success.
As far as my practice is concerned, I stop prostaglandin analogs and brimonidine 1 week before surgery and start the patient on low dose topical steroids. And this is because brimonidine can cause reactionary hyperemia on the table, and PG analogs cause the breakdown of the blood aqueous barrier. And one drug, if I stop one drug, I give Diamox during that period, half tablet 3 times a day. And in case I'm stopping 2 drugs, I give one tablet 3 times. So this is my protocol.
How many of us like to give mannitol in every patient of trabeculectomy pre-operatively, just for the audience? Do we all like to give, or it's not
Dr.
recommended
Parag,
in
you are
all?
coming. Mannitol and steroid. How many days pre-op you wish to start steroid?
Actually, I never use mannitol. Only in the certain condition that require trabeculectomy, like phygomorphic glaucoma, and that condition sometimes I use mannitol. But in the simple trabeculectomy cases, if I have to stop the prostaglandin analog, definitely you can stop it, and simultaneously you can start low potent steroid. And sometimes I aid placebo effect of some lubricants so that the patient feel happy, and after that we can do the surgery.
Dr. Lalwani, your 3 points.
One of the missing point is history. If a patient has nowadays comorbidity, so blood thinner or anticoagulant you should stop at least 3 days before. 3 days.
In
Usually
case
we
ecosporin, then it has to be
usually
five
we
days because the platelet, the life of the platelet, it's gets totally over in 5 days. So it's 120 days is the life of the platelet. So 5 days, 5 days is for ecosporin. Dr. Lalwani,
And
another
second
tip?
one is in intraoperative, you have to, if you are applying mitomycin C, then you have to take wider field. If you are taking a small field of application, then definitely encysted bleb of chances of encystic bleb is increased. And
Sir, Dr. Nayak sir, your 3 points.
Many points have been already told, but one point you should remember, that try to keep the hypotonous state during trabeculectomy for the least possible time, because the more time the eye will be hypotonous, the chances of choroidal detachment, choroidal effusion will be high, and that causes the shallow chamber and low pressure post-operative, and you will get confused whether my pressure is because of the bleb or it's because of something else. So it will give you a false sense that your IOP is controlled. So that is one. The second point, which was uh, that try to minimize the bleeding as much as possible, because blood, if there is a blood under the flap, it will cause more it will lead to fibrosis, and that will cause more chances of failure in due course of time. So, and of course, these releasable sutures, already it was mentioned earlier, and I prefer to cut the internal thing that you are making, the internal ostium. That one earlier I used to make it even with the blade or other things, but now I feel the sharper the edges, smooth edges, definitely gives you better outcome. So I always use punch for that.
So my 3 points. One is proper anesthesia. The patient should not be squeezing on the table. And second, which Dr. Naik also has said, there should not be any flat AC. Even 5 seconds of flat AC. I'm not talking of shallow. I'm talking of per operative flat AC. Even 5 seconds of flat AC can result in a minor ciliocoroidal detachment, which may not be visible unless you do UBM, which will be very difficult in the post-operative period, even if you have that machine. But so never, AC should never be allowed to become flat during the surgery, and one should immediately push in air if it becomes flat. And regarding the release of the releasable sutures, first is never remove the releasable suture in the first 3 days, because that can lead to extreme hypertonic. And never release two at a time if you have given multiple releasable sutures. Remove one, even if the pressure is gone to 30, remove one, give at least a day, and remove the later on, because even a single removal of a single releasable suture can lead to sudden hypertony, because that may be the offending suture. So I.
Now the time is getting over, so I just want to convey one message through the our panelist, that in medical treatment, when you're giving medical treatment, because we see a lot of mistakes and errors in prescription. So some of the things which you must avoid, and especially starting the combination, fixed drug combination. So when do you shift to fixed dose combination?
Sir, could you please repeat your question?
When do you shift to fixed dose combination of anti-glaucoma medications?
So number one, though, if the patient comes with a moderate or severe glaucoma, normally that time I do not wait for, and already patient is 3-4 medications, but IOP is not controlled. So in that case, BG analog and beta blocker combination, I would normally start in the morning because beta blocker doesn't work in the evening and the night, and also with the brinzolamide and brimonidine, another combination. Those were the severe glaucoma or the, I mean, moderate to severe. So with the 2 bottles and 3 times applications, like first morning in the prostaglandin analog and beta blocker, and 10 a.m. patient can use the Simbrinza, like, I mean, brinzolamide, brimonidine, and night is thing. But normally patient, when patient comes in the first time, or I have the opportunity to start the treatment, I never use the fixed combination at the beginning. First, I will start with PG analog, see the how it behaves, at least in one eye, then ask the patient to come for that. If that PG analog is not working, I try another PG analog, and then if it is not controlled, then I use normally, if there is no contraindication, I add one beta blocker. And if it works, then after 3 or 4 weeks, I just do that combination fixed drug, that is either latanoprost with beta blocker or travoprost with beta
Okay,
blocker.
thank you. So the already bell has rung. So means what she said is absolutely correct. First, you see, two medicines are required. So don't start with or means in the beginning only with two medications. One medicine, if it is not if it is efficacious and not sufficient, then you add other medicine. If both are efficacious, then only you shift to fixed dose combination. Because if you straight away start the fixed dose combination, then you will not come to know which one is acting, whether both are acting or only one is acting or one is not acting, and if producing some side effect, then which one is causing some problem, you will not come to know. So I thank everyone for this lovely session and all the audience, in spite of the having a lunch. Probably you were awake. I presume that you were awake, so thank you very much.
Thank you.
Uh, Once again, I invite all of you to the annual conference of Glaucoma Society of India to be held on October 6 to 8 in Pune, Hayat Regency, Pune. Thank you.